The D2D initiative came out of a need by the AMDA members, and particularly AMDA members who were in leadership position and tried to move the needle towards quality of care. And we identified that polypharmacy was a persistent problem that seemed to be very difficult to change. So we started on the D2D initiative. D2D stands for Drive to Deprescribe, but the tagline is really medication optimization. So it's not only deprescribing, it is optimizing of medication. This initiative involves several things. It involves teaching our stakeholders, our nurse practitioners, our DONs, our medical directors, and pharmacists about why we need to deprescribe. It teaches about specific deprescribing methods that are scientifically backed and evidence-backed. And it gives them a community where we can do an all teach or learn and really have communication with each other and profit from each other's experience. And then lastly, it has a data component that we are just starting to explore, looking at our successes or our failures and how we can course correct. So it's the why, the tools and the how, and then it's the goals. I think it's the need that we hit on, and it has been very successful in that we did several things. One thing we didn't want to do was talk a lot at people, so we try to keep it as painless as possible and make it as efficient as possible. So it doesn't involve a lengthy talks, lengthy written statements, nothing like that. It involves a webinar a month. We consciously chose one more teaching-based webinar and then another webinar the following month looking at an all teach or learn situation, and have people who have been successful talk about what they did and why they have been successful. And I think that last component has really driven a lot of people to, or drove them to it, and also made them stay, because their words could also be heard, their experiences, be it good or bad, could be validated. So teaching to a limited amount and a lot of kind of group learning and a lot of group cohesiveness, both of those were important. Yeah, so I think that is correct. We have patients with astonishingly high numbers of medications. So I think, first of all, we have old and sick patients, and medications just get layered upon layer upon layer. And then we have patients coming into our environment, and myself as an attending physician, I look at these meds and I have no clue why are they on these medications? And it's difficult to find that out. And then many of us are better safe than sorry. Maybe there's something going on that I really don't know about, because the care is so fragmented. It's even if I have access to prior records, it's immensely time consuming. I may not have specialty record access, so that we often don't know, are these medications there for a reason, or what reason is it? What goal does this medication have? Is it met or not? And then we'll just keep it. Plus, then something else happens, and we add to it. Very difficult situation. The other aspect of this is patients also are quite, at times, attached to the medication. Families may be attached to the medication, especially in our environment. Families may really be afraid that if you take something away, you give up on the patient. or you don't think they're worth it anymore. So I think these are conversations that we have to have with family members, that less is sometimes more, or is often more, I should say, and more is not always better, but that polypharmacy in and of itself presents a whole different disease states. I think what we can do about this is very strategically look at the number of medications and use the evidence that we have, and there are some great tools on our website. I like to use deprescribing.org that shows us how to safely deprescribe. And the other thing is really involve our facilities and family members in those discussions so that we are not dictatorial, but it is a shared decision-making process. I think the most beneficial findings of the activities was how much of an interdisciplinary team involvement that we were able to get. The pharmacists, of course, have been our collaborators all along. However, we have not been able, as a physician community or provider community in post-acute and long-term care, to harness that expertise. Often we were stuck, we were working in silos, we were stuck with canned pharmacy recommendation. And all of a sudden, we have realized we have this incredible tool, our pharmacy colleagues who can actually, are experts and can actually help us. The other thing was really, wow, there's a lot of team members who are involved in this, and we've had a lot of interest from non-physician team members. And I think that's been very critical to figuring out, yeah, if we do any other initiative again, we're going to involve those members, because you and I know, or all of us know, that in the nursing home setting, it can't just be a physician stopping a medication and hoping for the best. It has to be done with expertise and with a consensus, buy-in, and consent of the entire team. So we all have been going through quite a few medication and medication classes, and we will complete going through medication classes. One that comes to mind, of course, is antipsychotics. The other one that, although we have done some of that, we have done anxiolytics. The other one is antihypertensives. So there's a number of medication classes that we haven't touched yet. Certainly antibiotic stewardship will raise its head. But the thing that I'm excited about is really developing more tools for family members and really incorporating them into this process, and not in a sort of antagonistic way. Yeah, you gotta consent to this more, and let me show you why this is a good idea. And Jennifer Prukowski she is our content expert, if you will. She's currently, I think, writing or working on a project that really puts in very appropriately languaged family education in this, specific to diseases and specific to medications. I'm really looking forward in getting our family members involved, but not only teaching them, but them also teaching us why they would or would not deprescribe a medication or consent to deprescribing a medication. Well, I just would like to add that it's been an absolute pleasure to be involved with AMDA in this kind of initiative. It's, I think, the first of its kind, in that AMDA is part of driving a best practice, and I think we all learn from it. And I would like to, there are many aspects of post-acute and long-term care medicine where we need to drive practices. And I'd like to see this replicated once we are done with Drive to Deprescribe for other clinical issues that we have significant gaps in.